Honored to introduce Professor Hala Wakel, Professor of Nephrology and Internal Medicine, Alexandria. ومن الحاجات الظريفة إن هنبقى الكونتروفرسي بين اسكندرية وسوهاج from north to south. So please, Professor Hala.
Bismillah ar-Rahman ar-Rahim. Thank you, Mr. Chairman, for this kind introduction. First of all, I'd like to thank the organizing committee, namely Professor Ayman Rifai, who invited me to deliver this talk about the use of gadolinium in CKD patients, and I will conduct the pro concept. First, this is my agenda. What are the types of gadolinium-based contrast, and what are the long-term outcomes of gadolinium-based agents, and the risk factors for poor outcome, and hence the pro concept. As we know, gadolinium is a heavy metal of lanthionide group with paramagnetic properties, and the free gadolinium ions is highly toxic in humans as it competes with calcium ions in all biological processes because of the similar ionic radius, and therefore there will be inhibition of the calcium channels and blockage of all calcium ion-dependent enzymes as kinase and ATPase, and this will impair the cellular survival. For that reason, when the gadolinium is introduced in the body, it should be bound to a chelate carrier. And the chelate carriers may be linear or macrocyclic, and based on the charge, there may be ionic and non-ionic. And macrocyclic and ionic carriers bind more strongly to gadolinium ions with less toxicity. All gadolinium agents are excreted through the kidney, except for two agents which have dual excretion, renal and hepatobiliary. For that reason, in CKD patients, the gadolinium-based agents will be retained in the body with the process of transmetallation, where the free ions like zinc, calcium, copper will compete with gadolinium for the same carrier and leave the gadolinium free in the circulation with its toxic effect. As we know, the transmetallation will increase with the progress of the CKD classes. Moreover, there will be factors lead to more transmetallation, like the dehydration, hyperphosphatemia, and metabolic acidosis, and these are factors that could be inhibited to prevent such gadolinium toxicity. On the other hand, the macrocyclic and ionic gadolinium-based agents lessen this process. For the long-term poor outcomes of gadolinium, it comes on the top of the list, the nephrogenic systemic fibrosis, NSF, and less commonly the gadolinium deposition disease and nephrotoxicity. NSF is a devastating condition characterized by extensive thickening and hardening of the skin with excessive collagen deposition histopathologically, but this process becomes very rare since 2007 after the FDA issued a black box warning for patients with CKD using gadolinium of group 1. The NSF is a symmetrical, affect the skin symmetrically, but also there is a systemic involvement for the heart, lung, muscles, and others. For diagnosis of NSF, we have clinical and histopathological criteria. For the clinical criteria, we have major and minor. For the major, we have the pattern plaque, joint contraction, couple stoning, and marked induration and peau d'orange. For the minor clinical criteria, we have the puckering, the superficial NSF, the dermal papules, and the scleral plaque. For the histopathological, we have to find 4 of these criteria. For the clinical score, we have to find 2 major criteria. We will skip these 2 rare complications and come back to the NSF. What are the risk factors for NSF? We have patient-related factor and gadolinium-based related factors. For the patient-related factor, come on the top of the list, the CKD 4 and 5, AKI, pro-inflammatory state and impaired renal function, and renal immaturity in fetus, neonates, and infants, and consequently pregnant women. For the gadolinium-based agents-related factor, higher doses are risky above the standard dose, which is 0.1 millimole per kg. Multiple administration within a short time is also risky. As we mentioned, the type of gadolinium-based, the linear non-ionic, is risky. And the mode of excretion, if we have a dual mode of excretion, this will be more safe to our patients. For that reason, the American College of Rheumatology classify the agents into three groups. Group 1, which is now condemned, and Group 2 is safe with good evidence, and Group 3 is safe but with limited evidence. This is a mega systemic review and meta-analysis involving all studies that involve the Group 2 gadolinium-based agents, and they found that the pool incidence of NSF is 0 among the 5,000 cases of their cohort. And they conclude from their study that the risk is less than 0.07, and the harm of withholding the use of Group 2 may outweigh the risk of NSF in this population. And this is the largest study for the Group 3, which involve only 85 cases, and only half of them are on dialysis, and they report no single case of NSF within 2-year follow-up. As regards the dose, among this large cohort of almost 74,000 cases, using the standard dose, 0 cases were reported, and only the 15 cases were reported with a higher doses of gadolinium, and the single high dose is more injurious than the multiple standard dose. Other risk factors involve the hyperphosphatemia and metabolic acidosis, which increase the transmethylation, as we mentioned before. The pro-inflammatory events, which are an important risk factor for NSF, and this involved any cases with sustained major injury, like the major surgery, like severe infection, arterial and venous thrombosis, and all these have an intense healing process with following a major inflammatory pathway, and this can explain the onset of NSF. As regards the dialysis, the gadolinium chelates, fortunately, they are of low molecular weight, and they are hydrophilic, and they do not bind to the plasma protein. For that reason, they can be removed through hemodialysis. But the Canadian Association of Radiologists recommend that in patients with CKD 5D, hemodialysis should be continued after receiving the gadolinium-based agent, and should be performed on the same day, ideally 2 to 3 hours after the procedure. And there is no sufficient evidence to support the initiation of dialysis in grade 4 and 5 or change to hemodialysis from PD. So it is safe to give the gadolinium in CKD, but with this recommendation, with correction of risk factor, with adequate hydration, correction of acidosis and hyperphosphatemia. Macrocyclic ionic compounds of Group 2 is advised. The standard dose, not the higher dose. Multiple doses with spacing of at least 1 week apart from the 2 doses. And in CKD 5D, hemodialysis should be performed the same day as gadolinium, same day of the administration of the gadolinium, ideally 2 to 3 hours after the MR use. And thank you.
Thank you very much, Professor Hala, and we move to the second